Testing one, two, testing one, two, testing one, two, testing one, two. Testing one, two. Testing one, two, okay. Hey, Nick, good morning. Hello, Dr. Banty.
Hello, hi.
You're from Ethiopia, right?
Yes, I am from Ethiopia.
How are you
You are,
doing today? Can you put you don't have to put your picture on, but you could your camera on. It's good that other neurosurgeons get to know you, but you don't
all right.
have to if you don't want to. There you are.
I'm gonna do it for.
Neurosurgeons, they want to know who you are.
Oh, okay.
For the
All
rest
right.
of your career, you're going to have to stand behind that face.
Oh, all right.
You're not going to be anonymous. You're not going to be someone in the crowd. You're going to be Dr. Banty. This is me. This is my reputation. I
That's true.
participate in webinars.
All right.
And you don't have to say anything unless you want to. It's up to you. But to me, it's an advantage you can use for yourself. But you don't have to. A lot of people don't use it. But my advice is to use it. Okay.
All right.
Okay. Enough said about that. I've lectured enough.
All right. Thank you.
Okay. We'll be starting in a few minutes.
All right. Great.
Hey, John.
Yeah.
How are
Hey,
you?
Nick, how you doing?
I'm good. How about you?
Is that Nick?
No, it's Ibrahim.
Oh, how you doing? Hold on. I'm posting on Instagram now. Trying to
Okay.
advertise there also. No, I don't do that. Hold on. Okay, I'm back. Ibrahim, was that you that was talking before?
Yes, John.
Yeah, hi. Where you from, Ibrahima? You're from,
Guinea.
oh, Guinea. That's great. You've been participating for a while.
Yes.
Welcome.
I used to be in Shanghai.
Shanghai. Oh,
Yeah,
okay.
with Professor Xu.
With Binzu?
Yes, yes.
Oh my God, that was an experience, huh?
Was super great. I was even recently in US. I tried to message you, but I think you must be maybe busy, so I could not meet you over there.
Oh, okay.
I finally met Professor James.
Oh, that was something. He has a big crowd following him, right?
Yes, yes. I was in New Jersey. I met him from there.
Yeah. Hey, Nick, how you doing?
Yeah,
Hello,
it's
John.
good.
Hello, everybody. Excuse
Very
me,
good.
dear friend, that I interrupt you. Excuse me. I apologize.
It's
Ibrahima,
okay.
this
Don't
is
worry.
Nick from Greece, from
Yes.
the
Okay.
from the cradle of civilization in Athens.
Okay. Okay. I see that. And how is
Okay.
family? Everyone is okay?
Yeah, everything's good. Everything's good. And so you're back in Guinea, correct? Okay, we start in about 25 minutes. We start in 14 minutes. Testing, 1, 2, testing.
How you, John?
How you doing? Have I let you in there?
Yeah, you have. How things?
I'm using my backup.
Yeah,
My desktop took a dive,
is it?
so I'll try to get my main one working, but it'll be the same for you. It doesn't matter. So I'm
Okay.
just going to introduce you and you take over, okay?
Happiness, John, happiness. I'm here. I'm gonna put my camera off, but I'm here whenever you
Yeah,
get
you're
started.
good. You sounds good and everything.
Thanks. Cheers, bye.
Okay, we start in 5 minutes. We start in 3 minutes.
Hey John, how are you?
Okay, how you doing
Good to see you.
in Orlando? Orlando,
Yes, sir.
how are things going?
You're doing great. How are you, John?
Good.
Hi, Lulin.
Sam, how are you, Sam?
Hello. Good to see you, my friend.
Always good to see you. Always good to see you.
What's going on, gentlemen?
Hey, Richard.
Good to
How are
see
you?
everyone.
Welcome.
Good.
Reg, always good to see you, man.
Absolutely. Happens too infrequently. I got to get back to Africa, my friend.
Oh, I think so. And thanks for using a Sunday where I know you had absolutely nothing else to do.
It's okay.
No, thanks.
It's okay.
I really appreciate it, man.
No, absolutely. No, happy to support.
Thanks.
Hey, 1 minute. Okay, here we go. 10, 9, 8, 7, 6, 5, 4, 3, 2. Good morning from Miami Beach. This is Dr. John Bennett broadcasting for Neurosurgical TV. We have another of the AfPNS / AANS - CNS PEDS group webinar, and the theme of neuro-oncology. We have the very capable Llewellyn Padiaki moderating, and he's going to run the show. Welcome, Llewellyn. It's all yours.
Thanks so much, John. And I'm going to introduce just everyone else as well. So we're just reminded that this is very much a team effort. Can you see that, John?
Yes.
Okay, fantastic. So again, on behalf of the African Pediatric Neurosurgery Section, which is a number of people who I've introduced several times now, myself, Mohammed Al-Beltagi, Teddy Tortimer, John, who's speaking today, Ebenezer Tissot, and really a growing spectrum across the African landscape, with the goal of promoting and encouraging coherence and collaboration in pediatric neurosurgery within Africa and abroad. And our goal also is just to promote awareness and attendance and encourage people to attend the ISPN meeting hosted by Mohammed and the group, together with us from African Pediatric Neurosurgery, supporting that, which is in October 7 to 11. So please remember to come for that. Our previous webinar was beginning of Feb, which was really, really well attended. John tells us one of the better attended meetings. Our QR code, please, you'll see for those of you who have it, please scan that so you can get updates and join our sort of membership group from the AfPNS. So we're really thrilled with this webinar to have a host of really high profile speakers, panelists, and moderators. So the panelists who I'll introduce as they're going to speak is Professor Al Awabi, who's the president of CANS, Richard Anderson, who's the chairperson of the American AANS CNS pediatric section, and then Teddy Tortimer, who's one of our group and really has a whole list of accomplishments of his own. Moderating would be myself, Mohammed Al-Beltagi, and Ebenezer Tissot, and our really eminent speakers, who I'm incredibly thankful to for taking the time to talk to us, is Sam Al-Baba, and I'll introduce them just before they speak. Sam, who's a very prominent pediatric neurosurgeon now, who's done a tremendous amount of work, promoting and encouraging pediatric neurosurgery, endoscopy, fetal surgery, lots of sort of really relevant topics, and he's visited Africa many, many times. And I'm very thankful to Sam for taking the time to speak to us. And then James Balogan, who's one of our very own African neurosurgeons, African pediatric neurosurgeon and oncology surgeon, who is going to give us just an overview of nuances and relevant topics in pediatric neurosurgery. So I want to just make sure before we do anything is Professor Al Awabi, did he manage to join us already? I sent him a message. Prof. Al Awabi? Okay, so he said he was just outside of Rabat, but he was going to join us. And as soon as he joins, I'll ask him to also give us a welcome message. Then I'm going to ask Rich Anderson. Rich, who's right in the middle of a university function, but kindly and graciously, for those of you who know Rich, said he would make an effort just to join us and kind of strengthen this collaborative work that we're trying to promote between the AfPNS and the AANS CNS section. So Rich, I'm going to hand over to you quickly just to say a few words and welcome everybody. Thanks, Rich.
Greetings, everyone. Thank you so much, Llewellyn, for the invitation, and thanks to all the moderators and speakers who are participating. We're in an era where we all are recognized that high-quality research and education can really only be done in a collaborative international fashion. So this is really terrific, wonderful work that everyone's doing, and thank you so much, everyone, for joining today. I'm really excited for a wonderful session here.
Thanks, Rich. Thanks so much. And thanks so much, particularly for the support. And our goal is then to run this series of webinars leading into the ISPN meeting, but beyond that as well. And we're kind of, we're flagging these meetings with our various partners. So we've got one of the ISPN, the American section, and the ESPN Latin American section, and the IFNE, as well as the Asian Australasian sections, are webinars that we will have in the future. Okay, so I've just run through all of that. That's our website, wafpns.org, for those of you interested in finding out more, joining as well. I'm going to stop my sharing now. And Mohammed, if as well.
Llewellyn, let me just say one last comment, which is I forgot to mention, for any of you who have not made your travel plans to Cairo yet, absolutely do so, because it is going to be an epic meeting. Please come.
Thanks, John. Absolutely. Mohammed, I'm going to hand over to you as well. I see you've joined us. Mohammed's in Cairo at the moment. And Mohammed, maybe if you can then start by kind of introducing our first speaker. I think we're going to go with James, and then Sam will follow after. So Mohammed, you want to say a few words?
Yes, thanks, Llewellyn, for that introduction. And I would like to thank all our guest speakers and, of course, the moderators. And thanks, Richard, for the initiative. And also, I would like to add that we are looking forward to welcome you all in Cairo. This is a very spectacular place with a spectacular program, social and scientific, having over 11 workshops pre-Congress from 5 to 7th of October. And from 7 to 11, there will be a very special scientific program for the first time in the ISPN. So, and again, for the African, we are looking forward for abstract submissions, which is closing in 2 days. And mostly, we will offer scholarship for African pediatric neurosurgeons, especially those who are transplanted. To start with, the first speaker is James Malogan. Yeah.
Yep.
Hello, everyone. Can you hear me? Sorry, can you hear me and can you see me?
Yes, we can hear you, James.
Hi,
All
James.
right.
Fantastic. We can hear you. Yeah.
Hi, hello. Hi, everyone. It's good to see you, Dr. El-Baba. Nice to see you.
Good to see you, my friend James.
Yeah,
And Teddy.
So James will be speaking on nonsense in brain tumor surgery. So looking forward to hear from you, James.
Yes, please. Can you give me the right to kind of share my slide, please?
Sure. John, will you be able to do that?
I'm sorry, are you talking to me, Llewellyn?
Yeah. Will we be able to give James the right to share?
Well, it's up to him to share. I can't share his screen.
Okay, James, just try.
He has to share his screen or send his PowerPoint to someone else who'll share it.
John, there we go. James, you should be able to share. Yeah, great.
Okay, so yeah, so it's a great pleasure to be here, and thanks, Llewellyn, for exposing me as usual I was trying to kind of stay calm and quiet in all of this webinars, but he had wanted me to take this talk. And like he mentioned, I'm just going to give an overview of nuances in pediatric brain tumor surgery, and I will try as much as possible to kind of localize it within the environment that I practice, and particularly Africa, so that there's a good context to all of the nuances. So obviously I have no disclosures to make except for that which I have made, and I'm not sure whether I am an expert in here, but I've got a couple of people here who are going to add to this presentation, as it were, in terms of whatever is in deficit with that. But let me start that obviously one of the common things that we do mention every time is that children are not small adults. Children are children, adults are adults. The physiology and the anatomy for children are completely different from the adults. And just to make that also clear, the brain tumors in children obviously are also distinctly different from adults in terms of location. And we have common location for children when posterior fossa, cellular supercellular, and obviously hemispheric and posterior fossa, mostly brainstem tumors, which is kind of different from what you find in adults. The morphology is also very different. The biology is distinctly different when you have what is meant to be a hemispheric high-grade glioma in children. Obviously, even the molecular markers are completely different from that of adults, which is basically based on IDH mutations, and whereas that of the children in high grade is basically based on H3K27M. And we also found out that in the most recent WHO classification, that is the 2021 classification, not only were the common tumors that we have almost always been familiar with, also listed with molecular classifications, but newer subtitles were obviously added. Obviously, a number of them have evolved over the last couple of years before this 2016 or 2021 classification. And that was not surprising, particularly the ependymomas, which were then stratified as a follow-up to what actually happened in medulloblastoma. But obviously, other groups of gliomas were also added, and you also have variants of the H3K27, which is also listed as the H3 G34 mutants, and all other tumors that, again, are peculiar to children and were added as newly recognized tumors. Obviously, we know that from the 2016 edition of the tumor, the WHO classification, one of the obviously game changers that we thought way back then was the subclassification for medulloblastomas into subgroups of 4. We now know that in the newer classification, there's an attempt to further reclassify those groups just in terms of prognostication and predictiveness, or in terms of treatment and outcomes for those patients. And obviously over the years, particularly in what we will call the global north and the HICs, this has become somewhat routine in terms of really trying to stratify medulloblastomas, but obviously in what you will call the global south and the LMICs, there's still a challenge of this molecular classification, and obviously there's still a whole lot dependence on what we found at imaging, surgery, as well as basic H&E pathology. But obviously there's also moves in that direction to kind of close that gap such that we can also put these and infuse them into our clinical practice. It's also important to also state that the vulnerability of a child's brain, both the surgery that we will do and obviously the adjuncts, whether you think about chemotherapy or radiotherapy, is also vastly different. This is a growing brain. And obviously we also recognize in that same context that there's also the room for neuroplasticity in children, particularly in the younger children. And so you have to marry whether what you're trying to do is going to bring more insults to the brain, or you can actually push the frontiers a little bit knowing fully well that there's a potential for some recovery of function, particularly in this group of patients who we're talking about. Obviously, anesthesia consideration is a whole lot different and challenging. And when you contextualize that, particularly in Africa and in sub-Saharan Africa, where there is really no full stratification for pediatric neuroanesthesia. Again, you got to deal with general anesthetists. You got to make sure that who you're working with also pay attention to managing blood loss and also fluid management. And obviously, the real core pediatric neurosurgeons are really, really very key on temperature regulation. You know, things can really go awry if this is not done properly. Even though you've done a fantastic operation, this can actually just cause troubles for the neurosurgeons as well as for the patient. Obviously, I know that everybody is familiar with the fact that brain tumors have been really, the epidemiology of brain tumors in children have been established in the HICs, and I just particularly put the slide there just to say that obviously in the sub-Saharan Africa, when you did a systematic analysis, systematic review and meta-analysis, we found that gliomas were most common. Obviously, these were stated as not otherwise stated because there was no molecular marking. Medulloblastoma tend to prevail more in the southern part of Africa, and this is thanks to some of the research work that has been taking place in Southern Africa based on medulloblastoma over the years. And obviously, we also found that craniopharyngioma tend to also be common, particularly in the western part of Africa. Obviously, Albert Taggi and his group did this work of 5,051 kids from a large tertiary institution that is basically a children's hospital. So no surprises there with the volume. And you also see that the low-grade gliomas, if you add that to the high-grade gliomas, obviously were the most prevalent, and obviously medulloblastoma, as it were, as we will say, as one of the most common tumors also was present in the classification. So generally, what I'm trying to do here is to say that there is no tumor that is present in HICs that we don't see in LMICs, and particularly in African setting. We see them in different at different rates and frequency, depending on what the center is and depending on whether this is what the competencies of the neurosurgeons present in those centers. And quickly, just to give you an idea of what we do face in the situation, 4-year-old female child comes in with vomiting and gait instability. We see a posterior fossa mass essentially related to the tentorium. It's really not in the ventricle, it's outside of the ventricles, but it's compressing completely both the fourth ventricle and the aqueduct of Sylvius, which you cannot see really appreciate on this slide. But then associated hydrocephalus with transepidermal spread. And the first question that occurs to you as the neurosurgeon who receives this child is, what would you do? Child comes in, it's not your operating day, comes in on a call. Obviously, child has features of raising intracranial pressure from this tumor. And so you're faced with a dilemma of what exactly to do. And the first thing that strikes you is the fact that should you deal with this hydrocephalus preoperatively, intraoperatively, or postoperatively? The question is, what is your access to the operating room? How quickly can you get this child to the operating room? Even when you have access to the operating room, most 70% to 80% of these patients would pay out of pocket. Obviously, the child is insured or the parents have insurance cover. That makes life easy for you. But imagine that this child has to pay out of pocket and they don't have that money that day. What should you do? Should you just watch this child? After all, this child walked into the hospital with these features and still GCS15 is alert, he's awake, and he's responding to you appropriately. But we also know that any of these children, obviously, they're the candidates for coning at any time. And so you also think about admitting them to the ICU, but then there's no ICU space or PQ space, even for the children. So the question is, what should you do? We also know fundamentally that whatever you do to the CSF would also dictate what happens post-operatively. And we also know from the studies that had taken place a couple of years ago, which is now even the frequency was initially stated that only 25% of those children will need permanent diversion. And in most people's practice, actually, it's actually much less than that now. So the question is, should you wait to resect and treat the hydrocephalus? You're faced with all of this dilemma within constraining resources, and you have to make up your mind. You need to make the surgery safe for this child. Pushing on the brainstem is pushing on the fourth ventricle. You know that everything just has to go perfect for this child to be okay in terms of morbidity and even mortality. So, but this is just to show we're resected without any CSF diversion preoperatively, but I'll come back to the slide just to cite examples of what situation we would face. Obviously, the goals of surgery in any neuro-oncology case, pediatrics or adults, basically you want to obtain tissue for diagnosis. You want to do a cytoreduction, and obviously your focus would be most of the kids that we do see would present with raised intracranial pressure, and that would also help you to reduce that raised intracranial pressure. But most importantly, also, you must be able to improve, your focus must also be to improve on the neurological function, whether the child comes in with visual problems. Of course, if this is not an end stage and child didn't come in with blindness, you want to see if you can save vision. If child is hemiparetic, you want to see if you can improve that function and all of that. So again, those would be the goals of surgery. And the next thing to do is then to quickly start thinking about what's going to be your focus in terms of what extent of resection. Obviously, you could go from biopsy to gross total resection. We know that for most kids, when you see them, and most of them will, aside from the malignant lesions, most of them would be benign lesions, and gross total resection is like a cure for them most of the times. And so that will be the focus, but then you have to weigh at what cost are you going to get this gross total resection. So now we obviously move towards an oncofunctional resection, and this is much more important in children, or knowing fully well that in terms of quality of life, they've got a long number of years ahead of them. So education has to be preserved. They have to be able to learn. The capacity to learn has to be preserved. Reproductive capacity has to be preserved. These guys have to be self-independent. So in the true sense of it, it has to be that your resection is focused on maintaining function. And therefore, we've come back to this guiding principle to say that we want to do safe maximal resection. And I like to echo the fact that is the safe maximal resection truly, is it the same thing what you say when you say safe maximal resection in Ibadan, where I am in Nigeria? Is it the same in Accra in Ghana? Is it the same in Addis Ababa? Because it tend to seem that what we call safe maximal resection seems to be localized, is what I have in my disposition to be able to operate with, that guides me in terms of whether how much of the tumor I can really remove. So what I call safe maximal resection, leaving 30% of the tumor here in Ibadan, if that may just go to Ghana, and then they have everything that they need, and they remove the 30%, but then everybody quotes safe maximal resection. But again, I think it's a good guiding principle, and we can always localize it, but always know that perhaps you have to think in the background that maybe someone else can push that frontiers of what you are calling safe maximal resection. Obviously, when you then get to the surgery, the question is you have a workflow. You want to truly localize the tumor. Imaging for the surgery.
John, can we get
Okay, thank you. So we have to look at the tumor. Obviously, MRIs, which is now the gold standard of imaging for brain tumors, is obviously, the question is how much is it available everywhere, and what magnets density would be available. I mean, 0.3 Tesla MRIs are not comparable to 3 Tesla, 1.5 Tesla MRIs. The next question, in terms of preoperative localization of those tumors, would be, does the machine that's available in terms of MRI just doing anatomical delineation of the tumor, or you can proceed to physiologic and functional. And obviously, all of this would add to how much of tumor you can resect, depending on the functions around the tumor and whether you can really preserve normal brain function. Again, I would emphasize that that is absolutely important, particularly in children. So this is just a diagram. We have to localize the tumor. So the question is, what are the things that can help us to localize the tumor, push out tumor resection, and then preserve normal function? And I think those are the nuances that will be germane to talk about just briefly before my time runs out. And obviously, the reason for most of those adjuncts basically is to really push the limits of resection, and as well as to reduce surgical morbidity, such that the quality of life of these patients ultimately preserved, so that they can be self-independent, fertility is preserved, and obviously the earning capacity in terms of education, whether formal or informal, is also preserved. We do have a couple of things that could help us. We do have a couple of things that we could deploy in terms of brain surgeries, and I'll just run through and see how we get all of that to stimulate particularly residents and young faculty in terms of that. Obviously, everyone likes to have a modern neurosurgery theater as this. You want to see it. It's cute. Like a few people will say it's sexy. You want to enter the operating room and really feel like operating. When you're fatigued, you enter. It's like you're taking amphetamine. It just stimulates you to say, hey, let's go. But we know that this is not true for most places. Obviously, in the HICs, you'll find quite a number of this. And even then, it's not all of this present at all the time. But again, it would be nice to have some of these in the room where you want to operate. So quickly diving into localizing the tumor in terms of structural monitoring. Obviously, key there is neuronavigation and intraoperative imaging, particularly MRIs and intraoperative ultrasound and fluorescence imaging. And I just quickly delve into that. Obviously, one of the key features of neuronavigation for me is the fact that it does allow you to plan your craniotomy flap. I think for me, that's really big key. We know that the newer neuronavigational machines, and I'm not going to mention models, actually allows you preoperatively to do a lot more when in terms of fiber tracking, in terms of actually delineating fibers around the tumor. It's beautiful when you see some of those machines just using the MRI preoperatively to really do the work, and so that those also guide you in terms of maintaining functionality. But in terms of actually marking and really planning your craniotomy flap such that you don't have a big flap, the flap is really directed at the tumor, whether it particularly going in that longitudinal axis where you know it's easy, faster to reach the tumor, where you also will not again kind of just go through brain unnecessary function in brain. So this neuronavigation is very helpful. It uses anatomical landmarks, but obviously it can be subjected to initial registration accuracy, again, particularly dependent on each individual. But the truth is you do have text now in the room. It doesn't have to be you alone. And so that kind of takes that off. But obviously the limitations of neuronavigation, particularly is when you open the dura and there's a loss of CSF, there's brain shift, obviously. And then when you start debulking the tumor and with brain edema around it, it kinds of affect the accuracy of the neuronavigation. So some way, somehow, you cannot rely on it solely. But again, like I mentioned, you can have right there, as you plan, surface, then it shows on the surface, and then you see where the tumor is marked or right on the skull, and then you can plan your craniotomy flap towards it. And like I mentioned, some of the newer machines will actually give you the fiber trackings around and tell you what to avoid in order to be able to maintain all the functions. Obviously, this in pushing intraoperative resections to a real maximal way that you can, intraoperative MRI has been deployed both from the low field and the high field magnet strengths. Again, it has a big advantage in excision of low-grade glioma because you can actually follow through just like you see it on the MRI, that is preoperatively, and you can continue to resect the tumor. But obviously, this is not available everywhere. Again, it makes the operating room a little bit clumsy. And again, it depends. I mean, all the people, there are different ways through which to deploy MRI. Sometimes the MRI machine is in the room, but sometimes it has to be brought in. Sometimes some centers have it where from the operating room, you got to go down, again, straight into the MRI room. Again, it just makes a little bit of clumsiness, but obviously it works fantastic for those who have used it. And obviously technical issues sometimes can also lead to image distortion. Obviously, we know that we're talking preoperative MRI machines in centers that's not available. So this intraoperative MRI obviously is expensive, it's costly, even though it enables you real-time update of the 3D while you are just planning your flap. But again, there have been more arguments and obviously some randomized controlled trials have also shown that if you use intraoperative MRI, particularly for gliomas, and this would go for children, then also that the extent of resection is increased. And this is also assumed that once you have an increase in the extent of resection, the overall survival and the progression-free survival would also be improved upon. So again, I think it's just pushing the frontiers in terms of what tools we have to work with and to kind of push glioma surgeries in particular. But what I like is the ultrasound and neurosurgery. And I like people in this room. There are a couple of folks in this room, including Llewellyn, Mohammed, Dr. El Baba, and others who are very familiar with ultrasound in neurosurgery. And we used to call it the poor man's neuronavigation. Obviously, that is no longer true in the true sense, even though because there have been advances in intraoperative ultrasound in recent time, and you can do 3D, you can do strain, elastography. And I think leveling for some of the slides, particularly on this ultrasound, because again, this is something that he's very familiar with. This is the stuff. Obviously, this has also moved forward the fact that you can actually incorporate ultrasound into neuronavigation and have navigated ultrasound again. So this is kind of cool, and it helps you to really localize the tumor, and it's real time. You have real time feedback because as you're operating, this is not really affected by brain shift, and we know that it's low cost. Everybody here, particularly listening to me, most likely have an ultrasound somewhere in their hospital, and you can actually deploy this ultrasound and play around with them, particularly in trying to localize the tumors, both preoperatively before or intraoperatively before you start tumor resection, to localize the tumor and then to continue to use it as you continue to operate. Again, people say it does not require a high level of training, but in my opinion and from my experience, the learning curve sometimes can be steep because with this, the images are not what we're really as neurosurgeons very familiar with. But again, with use, I think it becomes something that you really found very valuable in terms of use. So obviously, again, even handheld ultrasound machines are now available from the phone, and you just connect a probe to it and you just use it. Obviously, sometimes the challenge would be how to keep things sterile, particularly when you don't have the sterile drapings. You can always kind of just improvise just to keep things going. Again, so thanks, Llewellyn, for this slide. You see the brain tumor here. Clearly, you see it on the ultrasound, and you continue to resect. The question here between this slide and that is whether you have residual tumor or not. And then you go ahead based on the fact that you see a little bit of residual, and then you go ahead to resect, and you have a clean space, saying that, okay, you're done with brain surgery, you're done with removing the tumor, and obviously you see the way to the aqueduct here. So again, just comparing intraoperative MRI and the ultrasound, again, bulky MRI, ultrasound is small, you can move it into the OR, it doesn't take space, it doesn't take a lot of time to really keep using it back and forth. and guide you in real time as you operate and take out the tumor. So basically, just to kind of back up, just to kind of pull a little bit, I pulled the slide here, and this is in a way of advocacy, particularly for the residents and the young consultants. You see the choice among African neurosurgeons in a survey. Again, spine, everybody wants to do spine. In pediatrics, it's just second, or it's almost the last one to functional, and functional is the last. And quite a number of people obviously are running towards spine and running towards core base and cerebrovascular. But I tell you that all of the specialties that you see here are actually all in this pediatrics. So you could actually be a pediatric vascular surgeon or neuro-oncology, pediatric neuro-onc. And so we need to kind of shift that attitude a little bit, particularly in Africa, and grow as much as possible, as many pediatric neurosurgeons as possible. Again, I put this table here because this also shows that as basic as ultrasound, which is going to be very helpful, particularly in our setting, it wasn't even mentioned in that equipment. Obviously, I'm also guilty because I'm also part of the author of this paper, but you see we're listing very high things, MRI, operating microscope, but then we forgot to list ultrasound. The other question about what also guides you to extend your resection is also fluorescence guided surgery. Obviously, this has been very well much more established in adults, particularly in high-grade gliomas. The use in low-grade gliomas is a little bit debatable, but a couple of folks are even pushing that frontiers to things like ependymomas, as well as even meningiomas. Well, we basically know that the commonest of these fluorescence-guided surgery is 5-ALA. It's an oral drug that's usually taken 3 hours prior to surgery. You shield the patient away from the sun because we know that the metabolism goes intracellularly, and the prodrug actually crosses the blood-brain barrier, and then you get the real glioma cells, which is the malignant cells, take up the porphyrins much more than the surrounding normal brain. And then obviously, as much as people think just having this violet blue filter is a lot of money to just buy in a microscope. And so that additional stuff can increase the fees or the money that is paid on a microscope, but obviously this is obviously worth it in terms of pushing the test for resection. This is what you see. And surgery, this is the white microscope light. You see this, and then you think maybe there's some normal brain around here, but when you turn over to the blue light and you have this fluorescence, you know that all of this is diseased brain, is all glioma invested brain. The other question is whether there's functional brain in there or not, but we all know that this should come out if it can, and that guides you in terms of the resections. What's the utility of 5-ALA in children? Obviously, looking at this review, gave 250 pediatric patients. It pushes and agrees that obviously it's safe in children and it's also effective. But we'll see over the years, again, how many people will adopt using 5-ALA. We also know that hemispheric high-grade gliomas are not as common in children as adults, and the high-grade gliomas or tumors high-grade are usually midline tumors, basically in the brainstem, and one the commonest, obviously, in our settings as neurosurgeons is DIPG. So the other thing is about neurophysiologic monitoring. Now, the question, basically, this is deployed when you think that obviously from the anatomy, you're operating around functional brain, and it's very effective in other ways to have a neurophysiologist in the room to monitor the MEPs and ASCPs, and also if you're operating on the post fossa around the fourth ventricle and in the brainstem in particular, where to monitor the cranial nerves. The other question is also whether if it's an hemispheric lesion to deploy using mapping, cortical and subcortical mapping, whether it is sleeping or whether it's awake. This would be also good, particularly in tumors around language areas or perirolandic tumors. Obviously, we do know now that this is very important for particularly languages. Language isn't really a defined place as we used to know it as the broadcast area, but we also know now that there are units connected together as networks that obviously control language, and then the location for first language and second languages, particularly for those of us who grow up in Africa, where you have to speak a couple of other languages and you have to learn English or French or Portuguese, then becomes something that have different networks, and it might be interesting to find out how those really come up in terms of surgical, how those affect surgical resection in Africa. Obviously, one of the cool things that have also evolved is the use of suction stimulator. Again, this is really cool when you have access to using it, because it just saves you the energy of having to resect the tumor, then take whether the bipolar or the monopolar stimulators and try to find out what is functional. You can have all of that in your suction as you continue to work, and that continues to delineate the functions around the tumors for you, and you know when you're going too far or too close to functions. And I'm sure that some of this work, 2-3 mm, you can also be safe in terms of resection. The question is also that you can also map the brain in an awake way. Again, this is established in adults, and it's been there for a while, obviously from different from different decades. People have deployed it for brain tumors, for epilepsy. Now, quite a number of people now do awake craniotomies even for aneurysms. So that's not far-fetched because, again, anesthesia, it's challenging, can be challenging, but it's a little more easier to do a local anesthesia than a general anesthesia. And all of that is dependent on how prepared the patient is. There has been back and forth movement from a bipolar electrode for cortical stimulation, monopolar. Again, more people are going towards monopolar now, but again, what you have access to is cool. And you can obviously prepare the patients. The question is, this is from Mark Bernstein, who is one of my mentors, and this is an adult patient that couldn't get one of our patients pediatric that we used back way then, but then this is what you get, and you resect the tumor. But question is, this paper came out from the San Francisco group, and Sean Jumper with Mitch Berger actually did this in his school to know that they actually operated on children. The cutoff age at that time was 10 years. This was in 2016. Mitch Berger actually started as a pediatric neurosurgeon, and obviously before devolving into adult glioma surgeries, but he still does pediatrics. However, I mean, it's debatable and you can argue, but someone like Hughes Defoe will say that additional awake mapping is really not additional surgical technique that we should talk about. Is really is really a philosophy, according to him, whether you believe that or not. I think it's just to put that in context of every time you have patients that might be able to go through awake craniotomy. Obviously, before that paper, like I said, at the CKIDS, we did review our patients, 10 patients who had pediatric awake craniotomy, and the youngest patient actually in our cohort was 11, and so maybe 10 maybe agreeable, and some people actually, there are reports that have done for 7 years old and 8 years old. I think the most important thing is to really know that the child has the capacity to withstand the procedure. He's not going to freak out, and that all would depend on how prepared preoperatively, psychological wise, and whether you have all the team present, including anesthesia, knowing what drugs to use. That's also going to be an anxiolytic, as well as also some form of mind sedation. And again, it depends on what technique you want to deploy, whether it's the sleep, awake, sleep, and all that. Again, that has to be tailored to your situation, to the team, and then particularly to the patients. I'm not going to spend a lot of time on this slide because obviously Sam is going to take the chunk of endoscopy in pediatric brain tumors, and that we have always, I mean, over the years, in different ways, have used endoscopy, whether as the only tool or as endoscope assisted brain tumor surgery. Obviously, for things like colloid cyst, people have used straightforward endoscopic resections. The question has always been whether endoscopic endonasal transpenoidal surgery is really safe and something that we should pursue in children. And over the years, obviously, different groups of surgeons have again documented that this is safe for these children. We do know that it's challenging with small nose. How much of nasoseptal flap can you raise? Obviously, they do have more of conchal sphenoid sinus, and because this is not pneumatized, oftentimes you would need neuronavigation. So the question is so that you don't go off the parts that you want to go. Therefore, even a transstellar approach, or even when you're just going for a transcribiform or transplanum, is a little more challenging in children because you got to drill a lot. Then you got to be in line, unlike the adults where you have a pneumatized sphenoid sinus. And as soon as you open the sphenoid sinus, you can see the full anatomy that guides you, particularly to where you're going, and then you don't necessarily have to have neuronavigation deployed in those cases. Obviously, Sam has this paper on purely endoscopic suprasellar infratentorial approach to pineal region tumors in children, and I'm sure that some of those is what he's going to talk about and obviously demonstrate how he does some of them. So the question again is, this part of the word, and you see a child like this, cachectic, huge tumor, and you're asking yourself, what should you do? This child's been with pediatricians, 32 months old child, presented with weight loss, common symptoms that looks just purely constitutional. These are constitutional symptoms that could be from anything, and then back you do a brain MRI and you get this kind of tumor, and now you know way back knowing that what this child actually presented with is diencephalic syndrome because of the location of the tumor, and this is the challenge. So the question is not just that we have competencies or we have the adjuncts to remove some of those tumors. Sometimes you are just incapacitated. This happens to be a pilocytic astrocytoma. Again, you cannot resect everything. Do you then, you have no access to kind of do the molecular marking, whether this is BRAF or no BRAF, whether this child can get chemotherapy. The question is, even when there's chemotherapy, can they have access to this chemotherapy? This is the kind of situation we're faced with. Therefore, we need to be familiar with everything that we can, such that our choices and our presentations to our patients are really cute and we can really help as many of them as possible. And we cannot just rely just on the general things that we do for adults and do the same for children. Therefore, there's always this issue of balancing the high quality care, having all of these tools and delivering this broader care. Because of time, I'm just going to not go through some of the slides, but again, I love the slides now. The slide is really something that speaks to me, that even as neurosurgeons in this part of the world, we're trying to put quality into our work. It is going to be intentional. It's never an accident. But even then, even while we're looking at growth, don't forget that we cannot grow just for the sake of growth, because even cancer cells take the ideology of growth, and that's why they cause chaos. So we need to be intentional. We need to really, really be focused, choose our fights, and be sure that particularly for these children, when we resect their tumors, we're not just winning the war, we're not winning the battles. We want to win the war in the long run so that these children can live quality lives. Obviously, I'm going to sleep on some of the slides in terms of that. And I want to thank the African Pediatric Neurosurgical Group. Obviously, Llewellyn had introduced quite a number of the folks, but particularly himself and Mohammed have been the real anchors leading the group. And I want to thank you. That I hope that we can be leaders, that we adjust the sails. We won't be pessimists, that will be complainants, and we will not just hope for change, but we will lead the change. Thank you for your attention.
Thanks, James. I can't thank you enough. That was just a superb overview and a masterclass, really. Just highlighting some of the realities, showing some of the things that we aspired to, and really these are nuances.
Thank you, James. That was very interesting.
Yeah, Mo, sorry, yeah. Let me hand over to you, Mo. Make a comment.
Yeah, thanks, James. It was very interesting, actually, the presentation. And I just want to highlight the use of ultrasound. Actually, in children, we have both the intraoperative ultrasound and the intraoperative MRI. But let me tell you that barely I use the intraoperative MRI. The intraoperative ultrasound being of high quality, the ones with high quality image is usually and actually a substitution for the IMRI, used in all cases, very user friendly and easily identifying tumor residual. And what also would be highlighted, the MDT, the multidisciplinary team in brain tumor, is extremely important to have a neuro-oncologist with you, because sometimes in very young children with choroid plexus tumors like carcinoma or high-grade tumors or whatever, we can start with chemotherapy, neoplasmas, and then you continue with surgery, becoming less vascular, easily removable, and also they can give you a hand in irresectable small parts of tumor and also residual high-grade tumors. And even in low-grade tumors, until recently, we didn't have the low-grade protocol tumor for low-grade tumors in chemotherapy, which was very helpful in tumors like chiasmal gliomas. So that's of very extreme important, and I think this has been introduced recently in Africa also, the MDT in most of the clinics in neurosurgical team and neuro-oncology team. And thank you again, James. So if there is any comments.
No, thanks, Mo. I think those are really, really relevant points. I completely support your point about the ultrasound. I'm going to ask Ebenezer Tirsit from Ethiopia just to make a comment or any additional points you want to make, please, Ebenezer.
Yeah, thank you very much, Prof. Lowell. Thank you, Prof. James, for the amazing presentation, and you highlighted the most important points we face in resource-limited setups, including getting a patient with extensive tumors, with bad conditions and delayed presentations. And among the things, we are recently seeing the having a multidisciplinary team and having a tumor board discussing the patient treatments before and after the surgery is very relevant, because some of the children, they are in a very bad situations, and even if we do the surgeries, so the outcome may not be that optimal. So the multidisciplinary treatment and preparing the patient from the outset and continuing the adjuvant treatment after the surgery have been very valuable, and thank you for pointing that. Thank you.
Thanks, Ebenezer. I think that's a really, really relevant point. Before I hand over to Sam and introduce him, maybe Teddy as well. Teddy's got a really sort of a good experience with brain tumors and pediatrics. Ted, any comments you want to make that are relevant before we hand over to Sam?
Well, just the fact that, it's so important to look at all the nuances as they come. And there are certain points where you can't improvise, and you just have to do the right thing. And how to make that balance, between, improvising to fit what the resources are, and then, just insisting on what the right thing is and how to do it properly. And how the impact is on, training, the extent of training that you need on the continent. But all in all, very important points, and really good learning for all of us. Thank you very much.
Thanks, Ted. And I just want to take the opportunity to thank John Bennett, who's been such a supporter of neurosurgery education, not just in Africa, but across the world, really. But I think he's shown such a focus and a bias, really, in some ways, to low and middle income countries, so Africa, Asia, South America. So thanks so much, John. And I think you agree, you're the one person who always says this, but the attendance of this webinar also reached over 80 at some point. So really underscores the need and the support for efforts like these to strengthen neurosurgery, pediatric neurosurgery, neuro-oncology in Africa and beyond. So thank you so much, John. So I'm going to introduce our next speaker. So Sam Al-Baba, apart from all the credentials that I'll mention, Sam is now the chief, and I think president, you guys call it, hey Sam, of pediatric neurosurgery at Orlando Children's. And has really done phenomenal work there since he moved across from St. Louis and built the unit into a really respectable one. And this is underscored by his commitment to endoscopic assisted procedures, not just tumors, but hydrocephalus, fetal surgery. So he's really done a huge amount, and he's been a big friend of Africa. Has visited us several times all over the continent. And I think for me particularly, getting Sam to speak here seemed really appropriate. And Sam, I can't thank you enough for taking the time, and we look forward to hearing you talk. Thanks, Sam.
Thank you, my dear friend Llewellyn, and I'm greatly honored and privileged to be with this wonderful group of colleagues, many old friends and many new friends. I belong to Africa. I love being there. I take pride of being in Africa a few times a year, and I look forward to continue collaborating with colleagues for many years to come, and above all, learning from you more than learning from me. We are in this together. I'd like to thank my friend James Blogan for the excellent lecture, an excellent overview, very thorough on the analysis of managing pediatric brain tumors. My talk will be focused on take a different angle, focusing on technical aspects in pediatric brain tumor surgery, including some skull-based pathologies, and primarily take a deep dive into how can we incorporate endoscopy in handling some pediatric brain tumors. I would like to acknowledge the excellent, superb work being done by the African Pediatric Neurosurgery section, and the level of collaboration with CANS, with continental societies focused on pediatric neurosurgery, with the ISPN. This collaborative work led by colleagues Llewellyn, Mohammed, James, Teddy, Ebenezer, and many others, is going to shape the future of caring for pediatric patients with neurosurgical conditions in Africa. This is tremendous work. Seeing the number of attendees through this webinar, thanks to John for facilitating it, tells us the whole story of what we need to do together in the future. Please join us in Cairo. It will be a terrific meeting chaired by our friend, Professor Mohammed El-Beltagi. This will be unforgettable meeting for the ISPN, and specifically hosting the meeting back in Africa after the last wonderful meeting in Cape Town. Bringing this meeting to Cairo is going to bridge many needs and gaps and help us all learn from each other. So I encourage all colleagues in the African continent, please do your best to be with us in Cairo. And do remember, for the ones who want to submit abstracts, the deadline is approaching. Here are my disclosures. I'll start by remembering what do we do every day? Specifically when we use the endoscope or microscope, it doesn't actually matter what technique we use. What matters is that what we do for the patients. Whenever we deal with pathologies deep in the brain or deeply seated lesions, obviously we always think about the gray matter we enter through, how much damage we use, the white matter tracts we traverse, ependymal surfaces surrounding pathologies. Let's say in the ventricles, we always talk about eloquent white matter tracts. We always talk about eloquent locations in the brain, like speech areas, motor areas, visual cortex. But I do remember my mentor, Professor Yassergal, used to say, there's nothing called eloquent part of the brain. The whole brain is eloquent, which means every time we put an endoscope or microscope or any instrument into the brain, we should always think about what kind of damage actually we're doing on our way to the pathology. But the field of endoscope-assisted microneurosurgery, which I will focus on today, is truly a remarkable advance in neurosurgery. I can tell you every time I'm up and have an endoscope in the room, and if I don't need it, I will use it during the case so I can help actually see if there's an opportunity to help the patient better, as well as improve the learning curve so I can maneuver in my skill towards going from endoscopic to endoscope assisted to endoscope controlled, and we'll go through this learning curve together. But Professor Pernetsky described this field into minimally invasive technique with a maximally effective treatment. With the junior colleagues who are in the webinar today, let's identify what are the different terminologies associated with endoscopy. Endoscopic is when we use the working channel of the endoscope, like when we do ETV surgery. Endoscope controlled is when the endoscope is primarily used for visualization, like in transsphenoidal surgery. The instruments are used in parallel to the endoscope. And endoscope assisted is when the surgery is performed primarily with classic microsurgical technique, but the endoscope can assist in different portions of the surgery to help with visualizing areas the microscope did not get us to. Why are we pushing in that direction? It's because the technology continues to improve. Some endoscopes are 0 degrees, some 30, 45, even 70-degree angle endoscopes can allow us to visualize parts of the brain or the skull base the microscope did not allow us to. And unfortunately, there's an unfair competition. You find two groups, some colleagues focused on old school microsurgery, some colleagues focused on new endoscopic techniques, and they attack each other. The truth is, this should be a complementary relationship rather than competitive. This view on the left side with a microscope tells you shows you everything on the way to the target, while if you stick the endoscope at the tip of with that microscopic view, you will see a different angle that the microscope did not allow us to, which is actually the truth. When you perform surgery, if you use both technologies, you find the view is different. So it doesn't matter if you do microscope or endoscope. If there's a capability at your hospital to have both, please consider using both. Let's take a deep dive into the pineal region. It's a complex region of the brain, given the complex anatomy associated with it. It's considered deeply seated. And then the field of pediatric neurosurgery, pineal tumors are some of the complex tumors that we approach. Question is, which approach we should use? At the end of the day, what matters is what you're comfortable with. Where do you stand in your learning curve? What capabilities you have at your hospital? What kind of support you have from anesthesia team? So many factors to consider before approaching a tumor, let's say in the pineal region. But the classic approaches are supracerebellar infratentorial, posterior occipital, posterior antehemispheric occipital transtentorial, or posterior transcallosal. But we have to remember that every time we deal with pineal tumors, specifically in children, over 50% of those tumors are germ cell tumors. So getting a tissue diagnosis can be extremely critical in deciding what to do next. But before we talk about which approach we use, we have to remember about, again, the learning curve and the comfort level. It doesn't matter what you do, supratentorial or infratentorial, midline or paramedian. At the end of the day, the surgeon's experience, your anatomical knowledge, and your comfort level and learning curve is, at the end of the day, defines what's the plan for this patient, or what is the safety track record. A few cases, what matters. It doesn't matter what other people do. What matters is what you're most comfortable with and what are the capabilities available in your environment. Whenever we talk about suboccipital approaches, we always remember the landmarks. the lambda, the external occipital protuberance, or the idiom, as well as planning and fashioning the craniotomy. It doesn't matter if you do super infratentorial, it matters is what you're most comfortable with. But whenever we talk about pineal approaches, we always talk about venous anatomy. There's a venous anatomy that is safe to sacrifice, which is not much, actually. Only the midline inferior vermiform veins, those are, yes, they're safe to sacrifice. But once you get laterally, any veins that drain directly into the petrosal sinus or the transverse sinuses can lead to Purcell-Foster syndrome, can lead to venous hypertension, to lead intraoperative edema that can complicate the operation and the outcome. So respecting the venous anatomy is key. But above all, understanding the venous anatomy is key before doing such cases, especially as we dig deeper in the supracerebellar plane, as we get into the superior vermiform veins, the precentral cerebellar vein, and the anatomy of the relationship between the basal veins of Rosenthal as to the vein of Galen, relationship to the thalami on each side. This anatomy has to get identified and understood before tackling those cases. Understanding the tentorial angle is key, looking at the imaging, deciding which is this a steep tentorial angle that makes it easier or more difficult surgery? Again, are critical things to consider. We will go through some selected cases. Today, we are unable to cover all parts of the brain or skull base that can be managed by endoscope-controlled or endoscope-assisted techniques. As my friend James said, there are uses in craniopharyngioma and other indications. Today, we'll focus more about midline pathology, specifically posteriorly in the pineal region. But whenever we talk about pineal region, we always talk about positioning. Semi-sitting position advocated by our mentor, Professor Yassergil, and many others. This has been performed since the 1970s. If you read the microneurosurgery series, you see just in 20 years, over 1,000 cases were performed in the sitting position by Professor Yassergil. Large number of them are children. Again, understand the tentorial angle is key, as well as thinking outside the box. We always talk about supracerebellar approaches to the pineal region, but how about to the brainstem? How about to the mesial temporal lobe? How about puncturing through the tentorium to get to mesial temporal lobe? How can this be safe and useful for the patient or not? But when we talk about children, what's the youngest age we can use semi-sitting position? And the truth is, it's all about your comfort level. In my practice, the youngest I can go to is around 18 to 24 months, and doing careful pinning and collaboration with anesthesia is key. At our hospital, we have a protocol. Every time we do a semi-sitting position, I like to get a CT scan to evaluate the thickness of the skull. Sometimes I raise my pins to the way just at the superior temporal line or a little bit higher to avoid the squamous portion of the temporal lobe and avoid fractures or temporal epidural hematomas. We do an echocardiogram to look for cardiac defects like PFO. Central line is critical for managing any intraoperative air embolism, as well as having a TEE, transesophageal echo. Working with a pediatric cardiologist can be critical for those cases if it's available. Going back to the pathology, as we talked about, over 50% are germ cell tumors. So a standard of care for the last 15 years, every time you're dealing with a pediatric pineal region tumor, getting a tissue diagnosis via biopsy, typically it's associated with an ETV, trying to avoid shunting. Like this is a 7-month-old baby with a large pineal region tumor with obstructive hydrocephalus. We plan for both ETV and a biopsy. It doesn't matter if you plan doing both at the same burr hole or not. What matters is safety. And I will show you some cases where you can actually make the decision intraoperatively. In this case, I did not feel good about doing both ETV and safe biopsy through the same burr hole. So I made an extra incision at the anterior hairline, and through an anterior hairline entry point, I access the pineal tumor. Now I'm looking from front to back At the bottom, you can see here the ETV we did earlier. Now I'm looking at the posterior third ventricle. This is the masseter intermedia, choroid plexus in the roof of the third ventricle, and doing now careful coagulation of the biopsy. Why did I decide to do a second entry point? It's because I did not feel comfortable based on the anatomy of this patient after doing the ETV that manipulating the fornix or the choroidal fissure is safe in this patient. And that's why I decided to use a separate entry point, not only for safety of the fornix or the choroidal fissure, but also for management of intraoperative complications, specifically hemostasis. Strategies for managing hemostasis after biopsy pineal tumors include obviously irrigation, tamponade with a balloon, or sometimes monopolar cautery. Can you do that with barely visualizing or not? And that's something you have to think about. Like in this case, after doing the biopsy, I got into some bleeding, but I feel I'm in a perfect position now to take have perfect visualization of the tumor at the biopsy site. I got into bleeding, and now I have perfect control with irrigation and balloon tamponading. This came back as a pineoblastoma, and I had to put the patient through, at the age of 7 months, in prone position, doing a supracerebellar infratentorial resection of this mass. You can see here after the resection, bilateral basal veins of Rosenthal. Let's take a look at second case, 15-year-old, same problem, pineal tumor with hydrocephalus. We did the same thing, ETV and biopsy. This came back as a germinoma, and this melted away with adjuvant therapy, radiation plus minus chemotherapy. So you have two different patients, both treated the same way. One ended up with a craniotomy and resection. The other one ended up with adjuvant therapy. 16-year-old boy, severe headaches, upward gaze palsy, CSF markers were normal. You can see here in every case, I'm planning 2 entry points. But when I go inside, like in this case, went for the ETV. After the ETV was successfully done, I feel good about the ETV. Then I visualize. Now I'm looking now at this is the ETV on the front. Now I'm looking backward through the same entry point, and now I feel good about getting a safe biopsy and hemostasis. So I ended up getting a safe biopsy. I feel good about the biopsy, not only about the biopsy, but also I feel good about managing intraoperative complications, which is key. So in this case, I ended up doing everything through a single burr hole, and that was an intraoperative decision. In this case, with adjuvant therapy, radiation plus minus chemo, the tumor melted away. How about endoscope-controlled options? This is a 14-year-old patient with a cystic mass. I monitored for a couple of years. As initially, I thought it's a routine pineal cyst. We don't like operating pineal cyst, but slowly this started getting bigger, and the content of this cyst started changing. Decision was made to operate. We discussed earlier the approaches. At this point, my learning curve, doing over 10 years of endoscope assisted resections, made me feel good about, you know what, I can do supracerebellar approach. The tentorial angle is very favorable. My comfort level is better, semi-sitting position, and I felt comfortable through a small craniotomy doing gravity-assisted, no retractors approach via endoscope control. In this case, after sacrificing the midline safe inferior vermian veins, now I am in the supracerebellar plane, right tentorium, left tentorium, right thalamus, left thalamus, vein of Galen, right basal vein of Rosenthal, left basal vein of Rosenthal, and here is the mass. After I saw all this anatomy, now I feel comfortable. And again, this surgery now, being done endoscope controlled with no retractors and 100% done with the endoscope, and the microscope is available in the room in case I need to get to it. Again, this is the vein of Galen, and this is the mass now surrounded by 2 basal veins of Rosenthal. And for me, this is a combination of sharp and blunt microdissection or endoscopic dissection. Now I'm separating the mass, cystic mass, from the right basal vein of Rosenthal. Again, this is the right thalamus. I'm going circumferentially to dissect this mass, but in the back of my mind, I'm thinking about the internal cerebral veins at the roof of the third ventricle. After circumferential dissection has been completed, I ask my assistant to hold the endoscope, and now I'm doing bimanual dissection. I'm doing 2 instruments while my assistant is using the endoscope, and you can see here, tectum inferiorly, and the right, and now we're dissecting the tumor from the right thalamus in this region. And now after the bimanual dissection has been completed, now we're retrieving the mass. Again, the dissection from the internal cerebral veins, a roof of third ventricle is completed, and the mass has been removed. All completely endoscope controlled. Now we put the endoscope back. Venous anatomy is preserved. Looking at the back of the third ventricle, right thalamus, left thalamus. Here we can see choroid plexus and roof, third ventricle, and no residual. And again, all the venous anatomy has been preserved. You can see here the internal cerebral veins, vein of Galen, straight sinus, and 0 retraction, injury, or edema of the cerebellar hemisphere via small craniotomy. This was the wrong thing to do 15 years ago for me because I did not have the learning curve. But again, after endoscopic experience with bread and butter endoscopy, then mature into endoscope-assisted approaches, doing the surgery with a microscope, and you bring endoscope during parts of the surgery, then I felt comfortable to mature into endoscope-controlled resection. In neurosurgery, optimal positioning is everything. And specifically when we deal with deeply seated lesions, again, understanding the tentorial angle, the armamentarium of equipment you have in the operating room, and your relationship and comfort level with the anesthesia team is key. How about endoscope-assisted resections outside of the pineal region, but in the vicinity of the pineal region? This is a 7-year-old child with temporal lobe seizures, classic semiology. By definition, this is a mass. We cannot call it like temporal or occipital. This is specifically posterior parahippocampal gyrus tumor. By definition, it's a ganglioglioma. It's enhancing mass for a child with seizures. If you show this to different colleagues, some will talk about classic mesial temporal resections, which on the dominant side, it's a very long reach. You have to resect a lot of the mesial temporal lobe to get to it. Some colleagues will advocate transcortical. This child had normal visual fields exam. This child had normal cognitive exam. This child was already on 2 medications for the seizures. And the third approach to consider for parahippocampal gyrus or medial or mesial temporal pathologies also can include supracerebellar transcensoral approach. But before we talk about the approach, the bigger question is, what are we doing here? Are we targeting epilepsy surgery or oncological safe resection? And the take-home message is the best way to answer yourself this question is looking at the FLAIR and T2 images. You can see here on T2 and FLAIR, you can see this edema surrounding the mass in the parahippocampal gyrus. For me, I don't need to resect the mesial temporal lobe. All what I need to do is to get a safe resection of this mass and keeping this child safe. Not about safety. I talk about motor and speech and sensory, but we have to think about visual fields. Talk about, this is dominant hemisphere. What's the potential impact on memory, short-term memory or long-term? So in a child who is normal otherwise, with this edema surrounding the mass, we start thinking about how can we get the mass out without doing too much excision or resection. When we look at lesions in the mesial temporal lobe and we look at the relationship to the tentorium, in the 1980s and 90s, mentors in the field have guided us towards the transtentorial approach to the mesial temporal lobe. In this case, we discussed the 3 major approaches to get to this mass. Obviously, nowadays, there's the option of laser ablation, which can be used for such cases. but at the time of the surgery and in many settings, this is not an available option, the laser ablation, but microsurgery is the way to go. Here we can see the relationship between the mesial temporal lobe and the tentorium, patient semi-sitting position. We monitored the right atrium of the heart the whole time. We performed a paramedian incision, as described by this paper from Professor Ture from the Istanbul group, and started the surgery with a microscope. This is the left tentorium. This is an opening under the left tentorium. This is the left cerebellum. It's key to open the cisterna magna early. As soon as cisterna magna was open, the cerebellum relaxed. Now I have a beautiful view, supracerebellar paramedian approach. Put in the endoscope, and now we're doing the transtentorial opening using the endoscope. So this is endoscope controlled tentorial opening. I'm thinking about also the trochlear nerve, shifted perihippocampal gyrus and tentorium. And now after the tentorium is opening, I'm looking now at the tumor. Very thin layer of perihippocampal gyrus was excised. And now doing classic microsurgical resection. You can see it's a calcified ganglioma, putting the aspirator through the transtentorial opening, supracerebellar plane, no retractors, mass is removed, and I feel good about it. Now I'm looking at the microscope, with the endoscope to finish the job. And you can see I'm embarrassed here because I left a good size residual lateral to the P2 and P3 segment of the posterior cerebral artery. And this is the view the microscope would never show you, okay? So now we did endoscope-controlled resection of the mass and the perihippocampal gyrus through a small tentorial opening, and we preserved the rest of the temporal lobe. And this is the P2 and P3 segments of the posterior cerebral artery. And here we got a gross total resection. Look in the post-operative MRI. This is post-op day 1. This is tentorial opening, gross total resection. And patient remains safe, no complications. But the most important thing is this. Take a look at this T2 post-operative image. Looking back at the discussion we had earlier, are we doing oncological or doing epilepsy surgery in this case? We're here not to resect the temporal lobe. We're here to preserve the temporal lobe. And look, as soon as the tumor was removed, the whole edema, as well as the seizures, went away. And this is on the flare. You can see here on the flare, again, the edema is gone. Other indications in the supracerebellar space, this is a 10-year-old child with an arachnoid cyst in the supracerebellar plane, extending into a septum cavum. This patient had mass effect. I monitored this without surgery for, I think, 1 year. And this kept getting bigger, and then a syrinx developed. And then I decided to approach it. Patient was placed in prone position, went with endoscope.
Okay, we seem to have lost Sam for a bit there.
You can reboot.
In the meantime, can we just get people to mute themselves, John?
Yeah, if Sam can reboot.
Yeah. Okay, great. So I think so Sam's,
He'll come back. He'll come back.
yeah. Okay, so just in terms of comment on those sorts of things, I mean, the endoscope is something we've used a lot. Well, you know, across kind of African management of hydrocephalus, arachnoid cysts, tumor resection. So we've got quite extensive experience. Sam, you're back.
Which slide did I lose you?
We lost us on that quadrigeminal arachnoid cyst with the syrinx. Yeah.
So can you see very well now?
Yes.
Okay, thanks.
Yeah. So the last a few slides here, we talked about these. We talked about epilepsy approaches. Talked about oncological. We talked about endoscopic. We talked endoscope controlled. We talked about endoscope assisted. And the last piece, we cannot forget microsurgery. This is a patient with headaches, vomiting, pineal mass. And we did an echocardiogram. There was classic PFO, patent foramen ovale, decided to approach this via prone position. But still, we use the same principles, microsurgery followed by endoscope assisted confirmation. Now the venous anatomy has been identified. This is the precenter cerebellar vein. And now we're doing resection in the prone position, but look, we're keep a close eye, precenter cerebellar vein, right basal vein, left basal vein. And now we put the endoscope back at the end of surgery. And now we preserve beautifully all the venous anatomy. I keep focusing on the venous anatomy because it's extremely critical for the safety of those patients. And now we're looking at the posterior third ventricle after the tumor was resected. Gustatory resection, but I love this view by post-op MRI that we're able to see beautifully the venous anatomy being preserved. Nothing without complications. You can have intraoperative air embolism, which is subclinical in all cases. You can have temporary peritonitis. You can have epidural hematoma, like in this case. For colleagues who are interested in exploring all aspects of supracerebellar infratentorial approaches, endoscopically or microsurgically, midline, paramedian, or in this paper, we collaborated with colleagues in Europe about the extreme lateral supracerebellar infratentorial approach. This paper is published in World Neurosurgery. With colleagues in Europe, we summarized different approaches that are extreme lateral supracerebellar approaches and can be used for tentorial pathologies, dorsal brainstem pathologies, mesial temporal lobe. You're welcome to look into this paper. Please feel free to reach out to me if you don't have access to it. So in conclusion, it does not matter what we do, microsurgery or endoscopy, endoscopic, endoscope controlled, or endoscope assisted. What matters is that we think about those approaches as we mature in our skill. Always think about the armamentarium of equipment that are available to you whenever you approach those lesions. Understanding of the anatomy is critical, patient selection, careful planning, partnership with colleagues from different services, including anesthesia, can be critical. And again, thank you so much for including me in your program today. It has been a great privilege to see you again today. Thank you so much.
Thanks, Sam. That was a really great overview and a very useful introduction to what can be often quite complex surgery. You underestimate the kind of technical nuance required to do these procedures. But thanks for showing us, complications as well as the successes you had and highlighting the difficulties and the benefits. So I think just from the colleagues still on the call, so Ted, perhaps if you're still around, you want to make a comment, Ted? I think Teddy may have dropped off. James, from your side, I mean, this sort of tag teams really beautifully with the talk you gave, right? It falls under this role of adjuncts and the role that adjuncts play in pediatric neurosurgery. But I want you to make a comment and then maybe just to leave a question to percolate that we can touch on later. And I'll ask you, Sam, to make a comment. I mean, we all show nuances and ways to remove tumors, but perhaps our best skill is when not to operate, right? Or when to refer. And maybe just you can make that point after James has made a comment. Maybe Mo as well, when not to operate. I think that's a very undervalued skill. James, any comments?
Yeah, thanks. Very good. I wouldn't expect less. I mean, he's a master. Right, so great. But I see that you're very familiar with the supracerebellar approach. It looks like that's your real comfort zone. Have you had to kind of go hospital transtentorial for some of those lesions? And why would you do that rather than the supracerebellar approach? Sometimes the question is actually like the nuance you showed about quickly opening the foramen magnum, opening the cisterns there, and allowing the cerebellum to kind of fall back. Because sometimes I see colleagues struggling, and it has happened to me before, where you're trying to really just kind of just retract the cerebellum, and then it gives you a whole lot of problems really getting forward. But again, how much have you really done in terms of occipital transtentorial compared to the supracerebellar approach? And because you do a lot more sitting position and go supracerebellar, would you also do sitting position for occipital transtentorial?
Thank you, my friend James, for the questions. First of all, 20 years ago, supracerebellar approach scared me because I was just not comfortable with the anatomy. I just thought it's a dangerous operation. And now, 20 years later, I feel comfortable offering it for a simple reason. Invested so much time studying, learning, going to the laboratory, watching colleagues operate, watching videos. And I always believe learning from others will always save you a lot of grief. So this is one of the areas where I learned a lot from mentors and colleagues in the field, including many in this room, like Mohammed and Lulin and many others. So the occipital, so the approach that I showed transtentorial was was supracerebellar transtentorial to the mesial temporal lobe. But doing supratentorial posterior interhemispheric transtentorial to the pineal region, I rarely use it, except for pineal tumors that are projected back posteriorly and superiorly. And the relationship of the pineal tumor to the vein of Galen and the internal cerebral veins, as well as the tentorial angle, how steep it is, makes me decide to go supracerebellar or supratentorial transtentorial. So the approach is decided on a case-by-case basis, and the relationship with the anesthesia team is critical. My colleagues from anesthesia, we have done large number of cases together, performing the operation using this approach and the semi-sitting position, and that's why I feel comfortable doing it. So to answer your question, number one, it's a learning curve. Comfort level did not come easy. It came the hard way after many years of practice, training, and learning from my own patients, learning from others. But defining the surgical plan to go supracerebellar intertentorial versus supratentorial interhemispheric transtentorial, it all depends, again, anatomical factors as well as the environment in the operating room. And sometimes, frankly, it's about what time of the day is it, what day of the week, which anesthesia team is available, who are the nurses in the operating room working with me and their comfort level. As you know, there are a lot of factors to consider.
Okay.
Thank you.
Thanks, James. Thanks, Sam. Mo, any comments?
Yeah, thanks, Samuel, for very informative and nice, interesting presentation as usual. I just want to highlight the part of the pineal tumors in children that when they always present, they present with hydrocephalus, and in Africa, as you know, they usually just shunt them first of all as an initial treatment. Then they close the approach for a biopsy. Although most of germinomas, as you know, and typical teratomas, immature teratomas, and other non-germ cell tumors are mainly treated by adjuvant therapy if they were biopsied first. So whenever there is hydrocephalus, for all of the recommend that we go with endoscope, take a biopsy, do the ETV, and after the pathology, we usually decide what is the further treatment, as more than 50% would have been a subject for just chemoradiology without any further intervention. In cases where you have referred cases after shunt, like already shunted and there is no place for endoscope, and so you just go for an open surgery, or would you do a stereotactic biopsy, because stereotactic biopsy in a pineal region sometimes is very risky from blood vessels.
So, the times when I had the opportunity to work with colleagues and operate in different African countries, I dealt with this situation where a patient comes in already ventricles are down because they were shunting done locally before referring the patient for the resection. So this creates a challenge. I am not in favor of stereotactic biopsy with needle biopsy, given the complex venous anatomy surrounding those masses. What I have used in the past in similar cases is doing a very limited suboccipital, small incision, limited suboccipital craniotomy, opening the dura, and with the use of the endoscope, like I showed earlier, even in the prone position, by relaxing CSF, we'll be able to get to the mass and get some tissue. Depending on the country, some countries are able to give you frozen pathology assessment, and if the frozen pathology guides you towards a tumor you should resect, then you extend the craniotomy, do a bigger dural opening. But there are times where we had to do an open approach to get a tissue diagnosis to define the next plan. On another hand, now what we have also done in the past, as you know, in many countries in Africa, flexible endoscopes are available. And I personally learned flexible endoscopy in Uganda. That's where I take credit, where all my experience came from, and I'm very honored that I learned it in Africa. The flexible endoscopy is a great tool in patients who have been shunted and the ventricles are smaller, but obviously not collapsed 100%. You can use flexible endoscopy with small ventricles to get a tissue diagnosis for the posterior third ventricle, and we had experience with some cases that were successful.
So have you tried changing the shunt with an external drain and just building up pressure to have CSF and then do an endoscopy again through the ventricle?
That's an option. I have
because
not
in
done
some
it
cases
before.
I have done this option. Yeah.
Yeah. Depending on the country where you operate at, some people use programmable valves. If the programmable valve is available, also it's another option to dial it up and blow up the ventricles to go get a tissue diagnosis. So there are different strategies. The EVD, like you described, Professor Beltagi, is a great asset. Doing endoscopic biopsy, if the ventricles are still feasible with rigid or flexible endoscopy. Obviously, stereotactic biopsy is an option, but in my experience, limited a small mini craniotomy can also give us a diagnosis.
Great, thanks.
Thank you.
Okay, thanks, Sam. Thanks, Mo. If there are any other comments, please just maybe raise your hand, and between John and I, we will unmute and you can ask your question. John, if you see any, please let me know. There are a few people on the call. Sam, so while we're doing that, I've sort of posed that to you, right? In our practice, we're neurosurgeons, we tend to want to operate, right? But I think the more you progress in your career, hopefully wisdom is something that builds with experience. And we all have those cases which we wished we'd never operated on, or we'd sent to somebody else. So what are your, because we've got some young people, looking for guidance. What are your thoughts on when not to operate? I know it's a broad question, but just as a closing kind of conceptual, philosophical comment.
Absolutely. They always say a surgeon is a good physician who can operate. A good surgeon is the surgeon who knows when not to operate. So as we put more gray hair on it, I think we operate less at times. Like the case I showed earlier with the pineal cystic mass, I monitored in the office for 2 years, assuming it's a pineal cyst, ended up being pineocytoma. So there's an area in pediatric neurosurgery that has been evolving in the last 10, 15 years, which is the area of incidentalomas. Many colleagues like Professor Keating, Professor Constantini, and others are telling us that, when you see a pathology, sit tight. Sometimes you have to monitor clinically or radiographically before you jump. Listen to others, discuss cases. Now in the era of WhatsApp and Zoom and other and emails, it's nice for colleagues to discuss cases. It's very common for me when I see a case that I'm not comfortable about, operator or not, I'll send it to you or to Mohammed or other colleagues on this call, and hey, take a fresh look at this case, and what do you think? A lot of times I would cancel a case I already scheduled when a colleague will tell me, you know what, sit tight, monitor. And I've seen a similar case that turned out to be something else. So incidentalomas that are asymptomatic, in general, I sit tight. I do not jump to operate. Pathologies that are stable, clinically asymptomatic and radiographically stable for a while, monitor. But the last piece that I think is extremely critical and important is the comprehensive collaborative approach for those pathologies, working with colleagues in oncology. We don't touch tumors at all without the patient being seen by the oncologist. I can tell you a few months ago, I was about to operate on a patient scheduled for a craniotomy. The oncologist came to me, said, you know what, the radiologist and I think this could be potentially either a CNS lymphoma, or it could be sarcoidosis or histiocytosis. Do you want to sit tight for now and do something else like lumbar puncture, markers, or maybe do limited biopsy? So I changed the whole plan, and they were correct. So talking to colleagues, not operating on asymptomatic patients, as well as discussing with non-surgical specialties like oncology, and colleagues from neuroradiology can be very helpful in making you decide when not to operate. And I would welcome and I would love to hear from you and Mohammed and others. What is your philosophy about when not to operate?
No, absolutely. I'll make some comments, Sam. But Mo, thoughts on, I mean, you guys have done an incredible volume now. When not to operate, Mo?
I think when not to operate, I think the Samer covered most, but most importantly, which I just teach the group working with me, the young, just not operate on radiology. They just showed me a scan for a kid who had a high-grade tumor and had a shunt, and you just brought him because there is a unilateral ventriculomegaly that they want to do aceptostomy. I just asked them, what is the complaint? But they said there is no complaint. He's coming on routine follow-up. We just brought the kid for the hospital because they found there is a unilateral ventriculomegaly. Fundus normal, no headache, nothing. So they were operating on a scan, but not on the kid. So what is most importantly is not to operate on the scan, just hear the history, know the indications of your surgery from the mother and from the kid himself. Like most of the arachnoid cysts, which we are seeing incidentally discovered with a midline shift and the huge cyst, but there is no single complaint. Just operating via an open surgery, endoscopy, or a shunt, then you suddenly, after a month, you discover a huge subdural hematoma or an intraventricular hemorrhage, and then complaints start once you have introduced this for a surgery. So don't operate on scans, but just operate on what is physically there. And most importantly, what Samuel mentioned is the oncology, the MDT, because we have to know if this surgery is indicated or there is an alternative. And if there is a residual, and it's like for the immature teratomas, when they start their chemoradiotherapy, then there is a residual, then there is an indication for removing this very small part, because this is considered the cure, and it will be a big difference in the prognosis. So the sharing with the oncology is very important. On the other hand, the low-grade tumor which you operated and there is a small residual, and you just want to do surgery because the follow-up MRI showed a residual, although he can be followed up until turning above the age of 18 to 21 years. He changed from a pediatric to adult. This tumor will stop growth afterward without any introduction of surgery. So sharing with oncology, don't operate on scan. And what is most important also is when to stop while you're operating. The use of intraoperative monitoring during the posterior fossa, CPA, or a brainstem exophytic tumor, when to stop before making this patient handicapped or bulbar symptoms or brainstem affection. Yeah.
Thanks. Thanks, Mo. I think you've just added the third point. We've done this so many times together now. So I think that's exactly right. So I think it's Shlomi who quotes the British neurologist Garfield. You can teach a surgeon, or his is a bit more complicated. So I'm going to paraphrase. You can teach when to operate, sometimes when not to operate, but it's most difficult to teach somebody when to stop operating. And I think that is the point that echoes through. So the thing we want to make, or the point we want to make to young people, get your principles right. The best surgeon is one who is well trained, who has learned from mentors, who is comfortable with what is in your hands, who knows when not to operate, when to refer, and the decision then to do an operation really becomes the safest, most appropriate decision for a child in this particular case. But that principle applies across all of neurosurgery, across all of surgery generally. So I was going to make one more, but I see we're already on quarter to 7. I think we've covered a good amount of time. So I'm going to start to wrap up now, Mo. So I think, as we've planned to do, as an African Pediatric Neurosurgery section, we're kind of running these webinars with all our international collaborators. We've done it with the ISPN, now with the AANS CNS section. Our next one will probably be with the ESPN in another 2 months or so, just kind of building up the intensity towards the meeting in Cairo that Mohammed's hosting. So we want to really drive momentum. Mohammed, you're running 11 or 12 pre-Congress workshops, something like that. Just
yes,
remind me.
11 workshops. 11 workshops. So they are endoscopy, craniosynostosis, epilepsy, tumor approaches, SDR, and spine by Richard Anderson, and hydrocephalus. What else? I cannot recall all of them now, but we're covering most of the most of the pediatrics.
The problem when you run that many workshops is remembering exactly what they were supposed. No, but thanks, Mohammed.
Yeah, the ultrasound and
yeah. So no, it's going to be
monitoring.
It's going to be fantastic. We look forward to it. Okay, so I'm going to close, and we look forward to our next workshop. We will post through. Thank John Bennett again. Thanks to our exceptional speakers, Sam Al-Baba, James Bellogan, and the rest of our moderators and panelists, and our attendees really from across Africa. I think, John, if you bear kind of sort of confirm what I'm saying, we had over sort of 80 odd attendees at some point. So really well supported and a much needed directive. Okay.
Yeah,
thank you so much.
Yeah, that was a well-organized, interactive conference. Quality education. It's going to be on YouTube forever. Okay, we'll see you next time.
Thanks so much, John. Thanks, everyone. See you next time.
Thank you, everyone.
Bye-bye. Bye. Thank you. Bye-bye.
Thank you.
Bye-bye. Have a great day. Bye-bye.
Okay, very good. Yeah, we almost lost that. I had to use my backup computer because my Zoom just went down on my other computer. So thank God that made it. Anyone want to say hello? We're off the air. We're off YouTube. Let me make sure I'm off YouTube.